has arrived.
Oh,
Yes,
I
I do try to start on time, Commissioner. So if you'd like to come forward and give us an overview of Department of Health and Human Services.
happy to. I'm going to invite a couple of my staff to join me as well.
And Commissioner, if you wouldn't mind shifting over to the other seat, it seems as if that microphone is more powerful than the one you're at, where you'll be doing the bulk of the speaking. You want to make sure you fill the room.
Okay, happy to. I am Mary Mayhew, Commissioner for the Maine Department of Health and Human Services. I have with me today Alec Porches. He is our Deputy Commissioner of Finance. And I also have Stephanie Meadow. She is the Director for the Office of Maine Care Services. And certainly, given the focus today on both an overview of the department as well as a budget briefing, I wanted to have them join me to provide additional commentary on this information. Now, Senator, I understood that there was a desire to provide, at least initially, an overview and background information on the department, in addition to the budget briefing. So I've already extended some apologies to the Health and Human Services Committee because they had the opportunity to hear much of the same presentation yesterday. So we'll be saturating with this message. There are, repetition is helpful, exactly, and there are PowerPoint presentations. We seem to be on a pattern here with delays in our PowerPoint presentations. So those will be arriving shortly. I will start. What we've tried to do today in this presentation is to provide a high-level overview of the department, the overall funding of the department, but then to get into specific information related to Maine Care, the state's Medicaid program. We've also included in your packets historical expenditures across all of the offices, the program areas, divided by fund between federal, block grant, general fund, and other special revenue. So you'll have that as well in your packet. I will begin, and I'll double back on some of these, but just as an overview of the organization of the Department of Health and Human Services. As many of you are aware, this is a very large department with a variety of programs, including, as I mentioned, the state's Maine Care program, Medicaid. This is a $2.5 billion annual program. The entire budget for the Department of Health and Human Services is $3.4 billion, state and federal. Additionally, the Office of Substance Abuse Mental Health Services is under our umbrella. The Office for Family Independence, which oversees the food stamp program, temporary assistance for needy families, providing eligibility determinations for Maine Care and all of the related programs, child support, collections, disability determinations. The Office of the Maine Centers for Disease Control is under our office, under our department. The Office of Aging and Disability Services. So we have provided in the presentation some additional detail for each of those offices and their respective budgets that I will go through. But just to start, there's often a discussion about the size and scope of the Department of Health and Human Services, and I think it's important to underscore that there is great benefit to the volume of programs that are within the Department of Health and Human Services. When we think about the individuals and the families that we serve, their needs don't fit neatly into one program area, and there is great opportunity as we look to provide integrated service delivery, a holistic approach to ensuring that the right services and supports are there to support individuals as they seek to regain economic stability. There are, however, this is a department that is the result of a merger of two departments dating back to 2004. There are still silos in the way in which the programs function, not all of which is simply as a result of organizational structure, but the funding streams sometimes exacerbate those silos. So we are continuing to look at ways in which we can address those silos, continue to support a more integrated approach to the delivery of those services. I use often as an example between child welfare and our Office of Substance Abuse and Mental Health Services. There's certainly a lot of shared efforts there to support parents with substance abuse and mental health services, to help parents reunify with their children. And we want to continue to explore ways in which those strong collaborations can occur, respecting certainly confidentiality and privacy laws. The department has 16 district offices located throughout the state. We have 9 administrative offices here in Augusta. And as I said, I wanted to go through some of the expenditures for state fiscal year 14 and provide a breakdown of those dollars. We have, as I mentioned, for 14, $3.8 billion was expended. Now, this includes an outlier expense related to the hospital settlements of over $400 million. Typically, the annual budget, as I mentioned, is closer to $3.4 billion. Of that, $1.9 billion is the federal funds. In terms of the overall funding for each of the offices, as I mentioned, the Maine Care program has the lion's share of the overall budget, $3.4 billion annual budget, $2.4 billion in the Office of Maine Care Services. The overall staffing structure, and again, as a large state agency, looking at our workforce and how we continue to improve upon our retention and recruitment related to our staffing, just to highlight. So in the Office for Family Independence, related to their role in eligibility determinations, there are over 979 staff in the Office of Family Independence. There are over 661 staff in the Office of Child and Family Services. I'm just going to pause. Can we see where those PowerPoint presentations are? Because obviously, the Health and Human Services Committee has the benefit of the slides that we presented.
And thank you, Commissioner. And if they aren't forthcoming, here it is. I know. Here in the nick of time.
In the nick of time. Well, there, I feel better. So we're going to start with the PowerPoint, and let's just start from the beginning. Just to quickly, I'll go over quickly those first few pages. So on page 2, Senator, we'll start with the organizational chart. I think the Health and Human Services Committee members on this side still need. We ran out?
Yeah, we ran out.
Awesome. Okay. We have some more.
Chair.
page 2, we'll just quickly go through the organizational chart and structure for the Department of Health and Human Services. You'll see on the left the Division of Licensing and Regulatory Services. Ken Albert is the director of that division. That division oversees the surveying of nursing facilities, child care facilities, hospitals, providing oversight to a variety of programs to ensure safety and quality compliance. That division also oversees the medical marijuana program. The next you'll see Alec Porteous, Deputy Commissioner of Finance, and of course Alec oversees our budget director and the development of our budget, our work in concert with the Financial Services Center, the contract management. The Department of Health and Human Services oversees thousands of contracts, and some of the work that I described yesterday with our process improvement to the development and issuance of contracts, the improvements to our request for proposals, processes for competitive bidding, a lot of great work underway to continue to improve the delivery of those contracts, as well as performance-based contracting and the development of measures to ensure that we are receiving value with the millions of dollars being spent through those contracts. The rate setting division, again, I spoke yesterday to the Health and Human Services Committee about the importance of that process and evaluating the rates of reimbursement being paid to providers to ensure that we are evaluating the costs associated with the delivery of services and care and trying to assess the challenges between our rate of reimbursement and the costs associated with the care being delivered. And then the division of audit. Next, Stephanie Netto, the Director of the Office of Maine Care Services, and we're going to come back and talk a little bit more about the Medicaid program. Sam Adolphson serves as our Chief Operating Officer, and I won't go through all of these, but you can see a number of the programs that report up to Sam, including the Office for Family Independence. Ricker Hamilton, our Deputy Commissioner of Programs. Ricker was going to try to join us today. Ricker oversees the Office of Substance Abuse and Mental Health Services. Sheldon Wheeler is our acting director. Jim Martin is the director for the Office of Child and Family Services. Gary Walcott is our acting director for the Office of Aging and Disability Services. Also under Ricker are the 2 state psychiatric hospitals. Jay Harper is the superintendent for Riverview Psychiatric Center. Sharon Sprague is the superintendent for Dorothea Dix. And then Dr. Sheila Panett is the director for the Maine Center for Disease Control and Prevention. The next, as I mentioned, is the map with additional information on our 16 district offices. On page 4 is the breakdown of the total expenditures, as I mentioned, for the department, divided among the various sources of funding. And again, for state fiscal year 14, $3.8 billion, but including the $490 million in hospital settlement payments. On page 5 is the breakdown, again, all funds, but based upon each of the office areas, and you'll see the Office of Maine Care Services is the largest portion of the budget here at $3.1 billion, with the next largest office being the Office for Family Independence at a little more than $250 million. Important to note, as we've talked about, although the Office for Family Independence oversees the administration of the food stamp program, the food stamp benefits do not flow through the Maine Department of Health and Human Services budget, so those are not reflected here. On page 6, looking at the breakdown of state general fund dollars for state fiscal year 14, the Office of Maine Care Services, $773 million. And then on page 7, our staffing. As I mentioned, the Office for Family Independence employs slightly less than 980 individuals. In the Office of Child and Family Services, 661 individuals. The next page, historical trends in staffing at the Department of Health and Human Services. 2005, just shy of 4,000 individuals employed by the Department of Health and Human Services. Today, we are at 3,456 individuals. This legislature has adopted in previous budgets attrition savings to work with agencies of state government to manage our vacancy rates. We certainly have been focused on evaluating across our department the efficient management of delivery of our services, and continue to look at ways in which to measure that to ensure that we have the right staffing to support the accomplishment of our mission and goals. You may recall, just as an aside, but as a good example, some of the discussions recently around child care licensing and the caseload sizes for our surveyors. And we recently had the opportunity to support additional child care surveyors to ensure that we were meeting that national standard around the caseload size to ensure more timely surveys for child care agencies. The next page, page 9, is just a historical perspective beginning with 2010 for Maine care enrollment. We've broken this out with traditional Medicaid enrollment by the various eligibility categories, and then similarly on page 10 with the other eligibility Medicaid enrollment. And we can talk a little bit more, but roughly in about 2002, the year 2000, around 180,000 people enrolled in the Medicaid program. Today, around 291,000. And we have another document in the packet that gets into some of the more detail around the current enrollment in the Maine Care program. Page 11, historical information on the growth in the Maine Care program. In 2002, about $1.4 billion. In 2014, $2.4 billion. As I said, Medicaid enrollment, again, increasing, peaking in 2011 at about 354,000 people in the program. The general fund obligations, as you'll see at the bottom of that page, in 2002, about $494 million required to support the state share for the Medicaid program. In 2014, $1 billion. Page 12, just again, information on the growth of the program. On page 13, information about the percentage over time of general fund dollars required to support the program, with roughly 13% in 1998, and today, in state fiscal year 14, 23.8% of the general fund needed to support the Maine Care program. On page 14, just breaking down the funds used to support the Medicaid program. And I just want to draw your attention, for those who lived through this, back in 2009, Maine benefited, as all states did, with temporary federal funds that were provided to states by Congress through the stimulus package providing temporary federal Medicaid support. Maine received a little more than $600 million in temporary funds. Those ended in June of 2011, and you can see the difference between 2011 and 2012 with the amount of state dollars, the blue bar at the bottom, that was required to support and sustain the program. I want to point out at the same time that that was occurring, where we lost the temporary federal funds, at the same time Maine in September 2010 had implemented a new claims management system to replace a claims management system that had not functioned as was required by the federal government, was not able to process all claims, and have a number of other significant challenges. The new claims management system, today we can talk about how what an incredible success it has been, increasing the time frame for claims payments from the previous system, which was on average in excess of 40 days, to processing of claims payments now between 7 and 14 days. Additionally, as you know, this legislature was focused on addressing the hospital settlement debt, but at the same time, included in that budget for state fiscal years 12 and 13 was addressing the core problem of the need to pay hospitals on a real-time basis. So all of that is reflected in that increase from state fiscal year 11 to 12 and then to 13 to address the true costs of the Maine Care program. On page 15, we are extremely pleased that we have been able to move away from the challenges of dealing with $50 to $100 million shortfalls, the crisis-oriented management of a program which has plagued the department and this program for more than 10 years. Obviously, it's difficult to look out 6 months, never mind a year, 5 years, 10 years with this program if you are staring at significant shortfalls. As we look at our forecast for 15, and certainly you can see the results of 14, where the program spent less in 14 than in state fiscal year 13. And then the forecast for 15 is just slightly less than 2% in terms of expenditure increases. And if you look at what is occurring nationally, much higher rates of growth, with 8.1% being projected for national Medicaid growth in the next 10 years. And I know this is a lot, and I'm sure we'll be back talking about a variety of information to support some of the analysis and assessment of the program, but I want to dive into where the money is spent in the Maine Care program and try to provide as much information in terms of where we have been focused on the last several years in the management of healthcare utilization, transitioning the Office of Maine Care Services from a transactionally focused program, claims come in, payments go out, to one where we are truly evaluating the health status of Maine Care members and how well they are able to appropriately access services, and we are able to manage the effective delivery of healthcare services. As you can see on page 16, 20% of our Maine Care members account for 80% of the costs. 5% of our Maine Care members account for 50% of our overall costs. Not surprisingly, in that 5% of our members, just so we're all thinking about the same individuals, we're talking about individuals who require expensive 24/7 services and supports, individuals in long-term care settings, nursing facilities, individuals with intellectual and developmental disabilities that require significant supports. Just as an example, an individual with intellectual and developmental disabilities who may require 24/7 residential services and supports and be included in one of our waivers, and we'll talk a little bit more about that. On average, their annual costs are over $100,000 per person. So certainly these are individuals with significant medical complex needs as well as developmental needs. But just to provide a background, as you can see when you look at page 17, just breaking down on average what the annual per member per year costs are for our top 5%, their annual per member per year is $68,562. And then when you look at the remaining 80% of the population, their annual cost on average $937. The bottom figure, the cost is per member per month. So just breaking it down on a monthly basis. On page 18, again, this is just attempting to provide more detailed information on where for the top 5 what the drivers are for the spend, and as you look at the neurological disorders, $350 million for individuals with intellectual and developmental disabilities, but certainly mental health services, behavioral health services across all of our members within the Maine Care program is a significant driver of the overall spending. Page 19, by service setting, where the vast majority of, for the top 5%, where the funding occurs. So again, for the top 5% of our members, accounting for $1.2 billion of the overall expenditures. The largest percent, not surprisingly, is in the long-term care setting, with 53% of the funding spent there. Stephanie, if you don't mind, I'm going to have you go through some of the federal mandatory services and optional services and into an explanation on the waivers, and then I'll pick back up.
Perfect. Thank you, Commissioner. And as the Commissioner mentioned earlier, my name is Stephanie Netto, and I'm the Director for the Office of Maine Care Services, and I appreciate the opportunity today to come and speak to the Appropriations Committee. As the Commissioner did say, some of this will be old hat for the Health and Human Services Committee, but it never hurts to have that additional overview. On slide 20. On slide 20 and 21, just a very quick overview of mandatory services and optional services that the Medicaid programs across the nation on the mandatory side are required to provide if we are participating with the federal government. And those, just very quickly, I'll highlight a couple of them: inpatient and outpatient hospital care, physician services, excuse me, home health services, and reimbursement to federally qualified health centers and rural health clinics. On slide 21, some of the optional services from a federal definition as optional, but that the state of Maine has chosen to cover: prescription drugs, dental services limited, private duty nursing, and chiropractic and physical and occupational therapy. So just a couple of slides that just represent the services and the service delivery package that we cover under the Maine Medicaid program. On slide 22 and 23, in addition to our state plan, and that really is our contract with the federal government, that is the document that outlines all of the services that Maine Medicaid will cover from a service delivery perspective. There is additional federal authority that the department can access, and those are called waivers. And we have a variety of waivers. They're listed on slide 23. For example, we have elderly and disabled waivers. We have intellectual disability or autistic disorder waivers, home and community-based waivers for individuals with physical disabilities. Individuals diagnosed with HIV/AIDS, there is a waiver that covers those individuals. And our transportation services are also under a waiver, a little bit different from the other waivers identified above. That is actually a managed care waiver. But a waiver really is the ability for states to have greater flexibility than what is allowed under normal federal Medicaid. It allows us to cover services that aren't coverable under Medicaid but necessary from a service delivery perspective. And you'll note on slide 22, it just mentions the primary requirement of a waiver is that the federal government would pay no more under the waiver than if it didn't exist. And a lot of times when we focus from a waiver perspective, specifically on home and community-based services, it is really intended to keep people out of institutions. We want individuals to have an ability to receive care at home or in the community and keep them out of institutions.
Yeah, I just want to, on the waivers, I think one of the challenges with Medicaid, federal Medicaid regulatory structure is that it's somewhat antiquated, has not kept pace with the way in which care can be delivered, the opportunity to deliver care more effectively at home and in the community where the federal Medicaid program truly has a facility bias. That's the basis for the structure. And while these waivers are helpful in providing states with greater flexibility, they can be, first of all, it takes time for the federal government to review and act on those waivers. It can take 2 to 3 years to receive approval for a waiver. They can be administratively burdensome to administer and detract from the overall goals of providing timely and effective delivery of services, and certainly to the extent that they, again, exacerbate the silos of how individuals benefit by focusing on their diagnosis as opposed to a more holistic approach. They can create more hurdles or barriers to providing those services. On the
Commissioner, if you don't mind, I've got a couple of burning questions.
Burning?
Oh, yeah.
Okay.
Representative Martin first, then Representative.
Representative Martin,
Welcome, Commissioner.
how are you?
Good seeing you again.
You too. I've been waiting for this.
Guess what, me too. Could you go back to 19 for a moment? Is there a way to identify the age groups on that, based on that chart?
Of our top 5%?
Right, within the top 5%,
Do
based
we-
on long-term care, hospital
Yes.
care, mental health care, et cetera,
Break it down by age demographic.
by age group. It doesn't have to be by, categories, but not, like 19, 20 minutes in there, but, for example, 65 up or in some manner, shape, or form.
Yep, I know we have that, so we can get you that, and obviously we can provide lots of data. There's some interesting analysis that we've also done on the
Right.
duals and their
Yeah,
service
dual.
utilization between Medicare and Medicaid,
Right.
so that might be helpful to share as well.
Yeah, that would be, thank you.
And Representative Gattini.
Thank you, Mr. Chair. Thinking about the comment that Stephanie made a couple minutes ago about the overarching requirement on the waivers that they be cost neutral, relative to what the cost would be for people in institutions. And thinking about the fact that we increased funding for nursing facilities last year, and I think there's proposals in this budget also continue to increase funding. I'd like to understand as we go forward what impact increasing funding for institutional services has on the waivers, and whether or not that potentially adds cost to the waivers or adds flexibility for us to increase rates under the waivers, and the whole interplay between cost neutrality when we raise rates on the institutional side, the impact that has on the waivers that would be important for us to know.
We will absolutely take that back.
Thank you.
So, just continuing on that, on page 24 is a list of the number of programs that includes both non-main care programs within the department focused on services for the elderly, in particular services that are not reimbursed under Medicaid, in particular looking at homemaker services, really supporting a more effective continuum of services, especially as we have an aging demographic in Maine, being able to support people as long as possible in their homes. Clearly, when you look at the average annual cost of that program at slightly more than $1,400 per person, that is an effective use of resources to potentially delay the need for more expensive 24/7 facility-based care. We currently have a wait list of more than 800 individuals on that program, and it's always difficult with wait lists. They're a point in time, and certainly as a wait list grows, people may not necessarily be adding their names to these particular program wait lists. The bottom half of the document pertains to a number of the waivers that Stephanie was describing and wait lists for those. Been a lot of progress in addressing certainly some of our wait lists on section 21. This is one that we spent a lot of time talking about. These are the individuals with intellectual and developmental disabilities who have a need for comprehensive services, 24/7 residential supports, in-home supports, rehabilitation programs, and as I mentioned, on average, annual costs of more than $100,000. Now, these are individuals that have access to Medicaid services, hospital reimbursement, physician reimbursement, pharmacy. What they are not gaining access to are the broader array of services and supports that are available through the waiver that are able to support when you, in the case of individuals with intellectual and developmental disabilities, when you deinstitutionalize, the need to ensure that we are effectively supporting services in their homes and in their communities. And so as you can see, a significant shortfall, and that is a big part of the budget proposal that has been submitted, and I'll get into a little bit more detail on that when we start to focus on the briefing on the biennial budget submission. The state funded needed for all of these programs, again, as a point in time, here is a little more than $54 million.
Time for another question?
Yep.
You don't mind? Representative Grant?
Thank you, Mr. Chair. Good afternoon, Commissioner. Thank you for all this great information. On the question of the folks that you were just mentioning that are on wait lists for services, what is the capacity right now in the state? Do we have sufficient community-based services out there? Is it a question of the money, or is there, and is it distributed, is this kind of capacity distributed around the state in such a way that people have geographic access to those kinds of services?
It's a great question, and certainly it's one that I know will be discussed a lot as we look at providers and their capacity. Certainly for providers of intellectual and developmental disability services, we want to see the capacity established in order to support the demand. The funding will clearly go a long way to help support that, but we're certainly interested in exploring with providers where some of the challenges are. Now, one of the other areas that affects capacity does pertain to other rates of reimbursement. So as we talked about the home-based care and those programs, the wages paid to direct care workers directly affected by the rate of Medicaid reimbursement. That's an area that we are currently studying so that we can come forward and provide some recommendations so that providers of those services are able to recruit and retain staff in order to support not only the need today, but the growing demand for these services. We also have done some work on